Today we are going to talk about the renin angiotensin aldosterone axis of the system, right? It is one of the very important physiological system which is doing a lot of function, but most important function is blood pressure regulation, that how the system regulates your blood pressure. So let's start first to understand its physiology, right? And to understand its physiology, let's take an example that due to some reason, if my blood pressure is going down, for example, I develop some hemorrhage or bleeding, I'm losing the blood out of my body, then how this system is activated? Because the duty of the system is, duty of renin angiotensin aldosterone system is to maintain my blood volume and to maintain my blood pressure. Volume and pressure in the vascular system should be regulated by this system. It plays one of the very important role. Let's disturb the volume and pressure and see what happens to the system. Example we take that there is a patient and he got a roadside accident and he is losing blood, right? Of course, now we'll discuss that how the system is activated. Let's suppose that this is the circulatory system of that patient, right? The organs which are going to play a role in this whole game is, number one, central nervous system, which is responsible for sympathetic outflow. We will talk about the kidney. Is that right? Rather drawing the full kidney, we'll draw a nephron here, right? So I draw a small kidney here, right? Then there's a role played by the liver. We'll talk about that. What is that role? And then very important role is played by pulmonary circulatory system. And of course, we will not forget the role which is played by adrenal cortex. Now let's start one by one. What really happens that when your patient is bleeding, let's suppose patient is losing the blood here, naturally blood pressure is going down and blood volume is going down. Is that right? Many things will happen in the body. One of the things which will happen that if patient is bleeding and blood pressure goes down, the blood flow to kidney will increase or decrease? Decrease. So first thing we'll say there is reduced renal perfusion. Now, whenever there is reduced renal perfusion, right, then veins from the kidney start bringing an enzyme in the blood. This enzyme is released in blood from the kidney. This enzyme is called renin. What I have said that whenever blood pressure goes down, kidneys start producing more renin and more renin come into blood. But first of all, we must study the kidney thoroughly, that by reducing the blood pressure, how kidneys start producing renin, right? For this purpose, I will bring one nephron out and show on the nephron the apparatus which is supposed to release renin. One kidney has how many nephrons? You know, kidneys have very specialized tube. You are millionaire as far as nephrons are concerned. In one kidney, there are about 1.2 million nephrons. But I will just bring out of this kidney one nephron out, right? Let's suppose this is the nephron here, and this nephron I'm going to draw outside to explain that how really this system works. This is one epithelial tube or nephron from the kidney, right? And we'll see how normally this nephron works in relationship to blood supply. Let's suppose this is afferent arteriole, which is bringing the blood to the nephron. These are glomerular capillaries, and here is efferent arteriole. What is this? This is afferent arteriole. Here it is efferent arteriole, right? And here is your nephron. Now what really happens? That we say that patient is bleeding, naturally blood coming to kidney is less, so of course blood flow to this nephron is also less. So afferent arteriole has poor blood flow. Now this is very interesting thing. Nature has put blood pressure measuring devices with every nephron. What a master system in the nature, that nature has put blood pressure measuring device with every nephron, so that every nephron knows how much blood is coming to it. Is it enough or not? So, Mr. Hidayat, you will tell me, what is the blood pressure measuring device with every nephron? Anyone has idea about? You have any idea? Every nephron has blood pressure measuring device. If you have 2.5 million nephrons right now in your two kidneys, there are 2.5 million blood pressure measuring devices with every nephron. Let me tell you one thing. You see, what is this? This was afferent arteriole. The smooth muscle, these are the normal smooth muscles, are afferent arteriole. As afferent arteriole approaches the, what is this? Glomerulus, right? Its smooth muscles become altered. They are no more normal smooth muscles. These are very specialized smooth muscles, right? And this group of very specialized smooth muscle, which are present in the wall of afferent afferent arteriole, this is blood pressure measuring device. These are the baroreceptors. It means nature considers blood flow to nephron extremely important. That is why nature measures the blood flow to every nephron, right? And this whole group, it has been given a special name. The name is called polkacin. Polkacin. So what is polkacin? Polkacin are made of a special apparatus which is made of what? Modified afferent arteriolar smooth muscle, which are able to measure the blood flow to nephron. And whenever blood flow to nephron become less, whenever the blood flow to nephron become less, they start releasing renin into blood. So it means they have double action. One action is to measure the blood flow, and second action is to release the renin. It means they are acting like an endocrine gland, because one group of cells releases the hormone into blood and acting into some distant area. So every nephron has a small endocrine system with it. Am I clear? This is a blood pressure measuring device. Whenever your blood flow is coming less and there's less pressure on this apparatus, as soon as this apparatus senses that blood flow is less or blood pressure is less, it will start releasing which substance? Renin. Okay, write it like this. It is the renin. So this is one way how renin is released by the special apparatus from the nephron. Now another mechanism is also there. First, understand normal. Normally what happens, that when blood is moving through the glomerular capillaries, there is some filtration done. There is glomerular filtrate. Am I clear? Now, this glomerular filtrate normally has lot of sodium and many other substances. Of course, what are these? These are the cells in the wall of nephron, right? Now listen, nephron has lot of cells in its wall. Now you see, normally when there's normal blood flow, then there's normal filtration. And filtration normally is about 120 ml per minute in the all nephron. This filtered material start going down. But because it has a lot of sodium, nephron cells take the sodium back to the body. Is that right? About 70% of the sodium or 60 to 70% of the sodium which is filtered, as it is moving through proximal convoluted tubule, it is reabsorbed back to the body. We don't want to lose the sodium. Then sodium keeps on moving forward, and about 25% of the sodium is reabsorbed here. If 65% sodium, if 100 units of sodium go down, 65 is reabsorbed here and 25 is reabsorbed here, how much is left? I think your math is not okay. 65 plus 15.
25.
65 plus 25. How much it become? 90. It means normally out of the filtered sodium, about 10% sodium comes here on this band. This is the end. This is the beginning of distal convoluted tubule, an end of the thick part of ascending limb of loop of Henle. Here nature has put a very beautiful system. There are some cells here which are very slightly modified structure, this group of cells. Here the nephron cells are somewhat modified. These are tall, these are dark looking, and these cells love to taste the fluid here. These cells are sensitive to sodium. They are sodium sensors. What is the function of these cells? These are sodium sensing cells, right? Now, actually, these are pressure sensing system and this is sodium sensing system. This system together make a whole apparatus. Now look, afferent arteriole with Pulcacin and this specialized group of cells from distal convoluted tubule and its junction with the proximal part. Is that right? This group of cell and this group of cell, they make one specialized apparatus. These acting as the baroreceptors and these acting as the chemoreceptors. These are the baroreceptors, these are the chemoreceptor. They measure the blood pressure, they measure the sodium concentration. Is that right? And they are held together by some connective tissue cells. They are held together by some, yes, connective tissue cells. Now, I told you this blood pressure measuring device, baroreceptor group, it is called Pulcacin. And this sodium sensing device, which is present in every nephron, it has a special name. You know what is the name of this special group of cells which measure the sodium? Thank God the researcher who found it, he did not put his name on this. Actually, in the beginning, when researchers looked at the nephron structure, they found this area was a little bit more dark as compared to the rest of the nephron. These group of cells are more dark. So they just call it macula densa. That there is some macule means patch of cell which is looking very dense. So this is called, what is the name of this thing? Macula densa. Now, Pulcacin is from afferent arteriole, macula densa is from distal convoluted tubule. This is vascular component, this is nephron component. This is pressure measuring device, this is sodium measuring device. And they are held together through connective tissue cells, which are called Lassus cell. All this apparatus as a group, is present in every nephron. It means every nephron has blood pressure measuring device as well as sodium measuring system. And as a group, Pulcacin plus macula densa, they have given a very special name to this, and all of you know that name. What is the name of this apparatus? What's the name of this apparatus? Yeah, juxtaglomerular apparatus. Have you heard of it? So this is juxtaglomerular apparatus. Just they call it a special apparatus, right? Juxtaposed to glomerulus. Juxtaglomerulus. With the glomerulus, there is a very special apparatus. Thank God they did not put a very complex name for it. They just say they're special apparatus. They never knew in the beginning what are its function. Now they know. Now, let's go back to our analogy. We were saying that person is bleeding. Blood pressure is going down. Blood flow is going, yes, down. So when blood flow is less, baroreceptors are activated in juxtaglomerular apparatus and they release renin. Meanwhile, when your blood flow is less, then glomerular filtration is more or less? Less, of course. If there's less blood coming, right, then filtration is also less. Now you think really with your own cortex that if filtration is very less, listen, if filtration is very less, the fluid will move through this lumen rapidly or slowly? Sure? So whenever GFR is less, luminal flow becomes slow. When movement of the fluid through the lumen becomes slow, then what happens? These cells which are working on this luminal fluid, they have more chance to work or less chance to work? More, my friend. Of course, look, if there are many mangoes going here, attention Mr. Hidayat, let's suppose there's water going and a lot of mangoes going here, and you are sitting here to catch the mangoes. If flow is very fast, you will miss the mangoes. But if it is very, very slowly coming, you will catch every mango. Do you get it? These cells work like you. They are not catching mangoes there, they are catching sodium there. So when blood pressure become less, glomerular filtrate become less, luminal flow become less, these cells extract extraordinary amount of sodium. And by the time the little fluid reaches here, it is more than normal amount of sodium or less than normal amount of sodium? Less than normal amount of sodium. Then macula densa, it loves to taste sodium. So whenever GFR is less, then proximal part of the nephron work on the slowly moving fluid, extract too much sodium, so less sodium reach to the sodium sensing device. And whenever macula densa feel there's less sodium coming, it becomes super active. It is activated when there's less sodium reaching here. And it releases some nitric oxide is released by it, and prostaglandins are released by it. And they activate these Pulcacin cells. Macula densa requests this, that please listen to us, there is very little sodium coming here, there is something wrong with GFR, probably blood is not coming well, so please release more renin. So renin release become further augmented. So now renin has been released under two influences, under pressure change and under sodium change. So every glomerulus has juxtaglomerular apparatus. Apparatus consist of blood pressure measuring device, and apparatus consist of sodium sensing device. Blood pressure measuring device is derived from the afferent arteriole smooth muscle. Sodium measuring device is a derivative of nephron cells. Together they make juxtaglomerular apparatus. Whenever blood flow is less to the kidney, right, this apparatus releases excessive renin in the blood. Now what this renin should do? Renin should correct the balance, bring the patient out of tragedy. What was the tragedy? Blood pressure was going down and blood volume was going down. Now function of renin is to bring the blood pressure back as well as blood volume up, so that patient does not die. For example, patient has lost 1 liter of blood, then somehow blood pressure should be maintained and somehow blood volume should be maintained. We will talk about how renin does it. But before that, we will talk about one more factor. What is that? That is that whenever your blood pressure goes down, let's suppose here is your heart. So what really happens? What is it? What is this? Carotid system is carotid body. What is the function of, carotid sinus, not carotid body. This is what I'm saying is carotid sinus. Carotid sinus is another blood pressure measuring device. It also has baroreceptor. When patient is bleeding, the blood flow to here will be more or less? Less. So whenever blood flow becomes less, this carotid system is also activated, and to special neurons, they report to the central nervous system that blood pressure is falling. They report to the central nervous system that blood pressure is falling. In the central nervous system, right? Okay, let's forget about this part of the diagram and concentrate only on this. This is going into peritubular capillaries, and then it collect back as venous, and okay, connected here. This was renal arterial flow, and this is renal venous flow, venous blood going back, right, and arterial blood. Let's come back. I was saying as soon as blood pressure goes down, carotid sinus through the sinus nerves, right, this is through the vagus, ninth nerve, glossopharyngeal nerve, right, this is messages given to the central nervous system that blood pressure is going down. As soon as central nervous system senses that blood pressure is going down, it will stimulate the sympathetic outflow through vasomotor center in the medulla. So from the medulla, fibers will come down, neuronal connections will come down and stimulate what thing out? Stimulate sympathetic outflow. This sympathetic outflow, which is going out, Suppose these are preganglionic sympathetic neurons, and here are postganglionic sympathetic neurons. I will not go to detail of all sympathetic fibers. Right now, we are concerned only with those sympathetic fibers which are coming to juxtaglomerular apparatus. These are sympathetic neurons which are coming to juxtaglomerular apparatus. Actually, as soon as blood pressure starts going down, vasomotor centers stimulated, lot of sympathetic outflow come. Some of the sympathetic fiber come to juxtaglomerular apparatus. And what they will release there? They will release, neurons will release norepinephrine. Right? And these cells have receptor for norepinephrine. These are beta-1 adrenergic receptor. What are these receptors? Beta-1 adrenergic receptor. You must know there are beta-1 adrenergic receptor present on juxtaglomerular apparatus because beta blocker block them also and help us in hypertension management. So the beta-1 adrenergic receptors present over here. So sympathetic outflow stimulate these beta-1 receptors, and when beta-1 receptors are stimulated here, more release of renin according to Mr. Hidayat speculations. More release of renin. So how many mechanisms are there to release the renin from here? Number one, 2 local and 1 systemic. Intrarenal mechanism is low blood pressure in the afferent arteriole and low sodium concentration to the macula densa. Both of them release renin. These two are intrarenal mechanism of release of renin. Extrarenal mechanism of release of renin is most important, sympathetic fibers connected with that. Is that right? So we see this juxtaglomerular apparatus can measure the pressure directly, can measure the sodium concentration directly, and in every emergency, whenever sympathetic nervous system will fire, renin will come. Now what this renin will do? Let's see what this renin is going to do. This renin is going to the general circulation. From the renin will go to the general circulation. Now renin has come to the systemic circulation, right, through the renal vein. Now what renin will do here? I told you renin is an enzyme, right? And every enzyme works on special type of substrate. It will also work on some special type of substrate. Before we go for that, you know, liver has a lot of hepatocytes. Hepatocytes produce a lot of protein normally. You know, they produce albumins and globulins, alpha globulin, beta globulins, but not gamma globulins, because gamma globulins are immunoglobulins, antibodies which come from plasma cells, B cells. But most of the proteins other than the gamma globulins, most, not all, but most of the proteins are produced by liver cells. Liver cell produce one very special type of protein normally, and this protein is called angiotensinogen. Angiotensinogen, right? Angiotensinogen, okay, I will write it in small way. This is angiotensinogen, right? From where it is coming? It is coming from liver, and it is not coming only during crisis. It is produced by the liver all the time. Right now, all of you have in your blood angiotensinogen. But as soon as renin comes, it will work on angiotensinogen. It will work on angiotensinogen and convert the angiotensinogen into angiotensin 1. It is angiotensin 1. So what is the function of renin? Renin is an enzyme which can convert angiotensinogen into angiotensin 1. Is that right? Now, all of you know it, that when angiotensin 1 passes through the lungs, it converts into angiotensin 2. That is the crux of understanding, na? That angiotensin 1, when it is passing through the lungs, it converts into angiotensin 2. It means in the lungs, there should be some enzyme which convert angiotensin 1 into angiotensin 2. And that enzyme is called angiotensin converting enzyme. Again, when angiotensin 1 passes through the lungs, it converts into angiotensin 2. Angiotensin 2. right? When angiotensin passes through the lungs, it converts into angiotensin II. This is large protein molecule. It is decapeptide, 10 amino acid. Then there is an enzyme in the lung which breaks down 2 more amino acid, and this product is octapeptide, only 8 amino acids. I want to know one thing. Angiotensin converting enzyme, on which so many drugs work, angiotensin converting enzyme are present in which part of the lung? Are they present in bronchioles? Are they present in alveoli? Are they present in capillaries? Are they present where? Where in the lung angiotensin converting enzyme is present? All of you know there are many drugs which inhibit that enzyme. We must know where is that enzyme. Yes, we talked to Abbas. No idea. Jamie. Same. Yes, Hadayatullah. You are with the majority, or you will try to guess something? In the lungs, everyone has heard there is an enzyme called angiotensin converting enzyme. Have you heard of it or not? MashaAllah, you have heard of it. Where exactly it is present? No idea. No idea. Jamie, just guess it, wild guess. You don't want to even guess. Maybe it is present on the pleura. Yes, any wild guess. Alveoli. What do you think?
Yeah, it's
Pneumocytes. Okay, write it down on the book and put a very big cross on this. You know why? If it is present in alveoli, then tell me one thing, it means your blood has to pass through alveoli. Alveoli are blood flow system or air flow system? The air pockets or blood pocket? Yes?
Capillaries now alveoli?
No, the alveoli are air pockets and pulmonary capillaries are attached with them, but pulmonary capillaries are not alveoli themselves, right? So, one thing is sure, alveoli should not have the enzyme, otherwise there will be tragedy. Blood has to jump into alveoli so that angiotensin 1 should convert into angiotensin 2. Okay, let me explain. Actually, here is alveoli. Let's suppose this is airway, and these are suppose alveolar system. These are air pockets. Of course, blood should not enter there. Is that right? Actually, on the endothelial cells, what are these? Endothelial cells of pulmonary capillary beds. On the endothelial cells, there is a unique enzyme expressed. This enzyme is expressed on the surface of endothelial cells. That is why this enzyme is called ectoenzyme, because this is not intracellular enzyme. This cell is expressed on the surface of endothelial cells, right? Not released into blood. But now they believe that not only pulmonary capillaries have capacity to convert angiotensin 1 into 2, even some other capillary beds can also do this function. But for your level, you just remember that in the pulmonary capillary endothelial lining, they are expressing enzyme called, what is the name of these enzymes? They are very angry because you don't remember where they are. You look at their expression. Right? These are which enzymes? Angiotensin converting enzyme. What they are doing? Actually, they are responsible to convert angiotensin 1 into angiotensin 2. This is a function of these enzymes. These are the function of these enzymes which are called angiotensin converting enzymes, that they convert angiotensin 1 into angiotensin 2. And when we talk about the drugs like captopril, enalapril, lisinopril, or other angiotensin converting enzyme inhibitors, those drugs basically bind with these proteins and block their function. When we say there are whole group of drugs called angiotensin converting enzyme inhibitor, what is the function of those drugs? These drugs are basically bind with these enzymes and blocking their action. Every doctor knows that these enzymes are converting angiotensin 1 into angiotensin 2. But some good doctors know they do also one more function. What is the second function of these enzymes? There is another product in the blood which is called bradykinin. There is another product in the blood which is called bradykinin. Bradykinin is broken down by these enzymes. Bradykinin, look at it, because it is inactivated. Bradykinin inactivation. Bradykinin is vasodilator. And angiotensin II is vasoconstrictor. So what is the function of this enzyme? These enzymes break down the vasodilators and produce vasoconstrictor. Of course, when blood vessels will constrict, blood pressure will go up. Am I clear? Now, so again, let's recap up to this. Patient was actively bleeding, right? It will take some time. Renal perfusion is reduced. Then what is this? Blood pressure sensitive cells release renin. Plus, macula densa senses low sodium coming here, a sign of low GFR that also forces the cell to release renin. Moreover, falling blood pressure activates the sympathetic outflow, and sympathetic fibers coming to the juxtaglomerular apparatus further release of renin. This renin is an enzyme which comes into general circulation and break down the angiotensinogen into angiotensin I. And when angiotensin I is passing through mainly when it is passing through the pulmonary circulation, then angiotensin converting enzymes which are normally expressed on the endothelial cells of pulmonary circulation, they convert angiotensin I into angiotensin II. So they produce very powerful vasoconstrictor. And of course, these enzymes are very active, very intelligent. While they're producing vasoconstrictor, they don't forget to inactivate the vasodilators like bradykinin. Now we have the angiotensin II in our circulation. Now we have to see what angiotensin II will do in the body. What it should do? It should bring the blood pressure up and blood volume up. That was the problem, no? So now we see how angiotensin II is going to achieve its function. Let's come to the actions of angiotensin II. First, we'll talk about the classical action. Number one, angiotensin II, okay, I will draw here circulatory system in a little detail. The left heart, and these are the arterioles. From the aorta, these are the arterioles. And here is your right heart. This is the venous system. And of course, in between these arteriovenous system, there are, what are these? Capillary beds. I hope you must know. Blood comes from arterial side, passes through the capillary beds, and then it is drained to the venous side. Right? This is right heart and that is left heart. And of course, you will not forget to draw that there must be lung over there, that this is your pulmonary circulation, and blood gets oxygenated over there, and then it comes to the left atrium, and of course here is your, what is this? Air spaces. Clear? Now we'll see first of all what is the action of angiotensin II on this system, because pressure and volume is falling into this system. First of all, angiotensin II has receptors on the arteriolar smooth muscle. What are these? Arteriolar smooth muscle. Angiotensin II receptors are present on arteriolar smooth muscle. Plus, angiotensin II receptors are also present on the venular smooth muscle. So they are also present over here. Right? Now what really happens? Number one, angiotensin II will work on, what is this? Venous smooth muscle. When angiotensin II act on the angiotensin II receptors on venous smooth muscles, veins constrict. When veins will constrict, can blood remain pool into vein? No. Most of our blood is normally present in the veins. Veins contain about 70% of total blood volume. That is why we call them the vascular component with the highest capacity, or simply veins are called capacitance vessels. So angiotensin II will constrict the veins. When veins are squeezing, pressure in veins will go up and blood will rush towards where? Where the blood is going? To the heart, and then to the eventually left heart. So under venoconstriction, blood going to the left heart is less or more. When you squeeze the vein, venous return to the heart is increased. Now listen, when blood flow increases to the left heart, it means cardiac filling is more. So venous return, venoconstriction lead to increased venous return, that lead to increased cardiac filling. Increased cardiac filling lead to increased end diastolic volume and increased end diastolic pressure. At the end of the diastole, volume and pressure is more in the ventricle. So ventricle is stretched. And according to Frank-Starling law, more you stretch the ventricle, more it contract. Frank-Starling law is stated that within physiological limit, more you stretch the myocardial cell, more they contract, of course, within physiological limit. Don't rupture them, right? Now, so whenever venous return is more, end diastolic volume is more, we say that preload on the heart is more. And whenever preload on the heart is more, preload is the amount of blood in the ventricle on which it has to produce contraction. Is that right? So, whenever there's more blood accumulated here, more it is stretched, more it contracts, so stroke volume will become more. So that will lead to increase stroke volume. That will lead to increase stroke volume. And of course, when stroke volume is more, then what is there? Increased cardiac output. And when there is increased cardiac output, that will lead to increase in systolic blood pressure. That was the point we wanted to reach. You know, our systolic blood pressure was falling as well as diastolic blood pressure was falling. When your bleeding was going on, for example, bleeding was from here, so blood pressure was falling. So by venoconstriction and increasing the venous return to the heart and increasing the end diastolic volume and of course increasing the contractility and increasing the stroke volume resulting into increased cardiac output, eventually increases systolic blood pressure, because systolic blood pressure mainly depends on cardiac output. Am I clear? During the systole, blood pressure will go up. Meanwhile, angiotensin II will also work on, what is this? Arterial smooth muscle, and arterioles will constrict. Now, if arterioles will become very narrow, during the systole, when a lot of blood come here, can it easily move to that side? No. So even if heart is not pumping, because after the systole, heart will undergo relaxation. There will be onset of diastole. During the diastole, of course, aortic valve closes. Blood cannot go back. The only choice for the blood during diastole was that no blood coming during the diastole here, but whatever blood is pumped here, that should rush to the capillary side and venous side during the diastole. Now, if arterioles are open too much, most of blood will run forward and pressure in the diastole will fall. But if arterioles are too narrow, they are tight, do you think blood which is present during the diastole here, can it easily move? So blood will be retained on the arterial side, and pressure in the arterial tree during the diastole will be also increased. And we say that diastolic blood pressure increase. There is increase in diastolic blood pressure. So that was our target. What was the target? That when we were losing the blood, systolic and diastolic blood pressure were going down. By increasing the venoconstriction and venous return, we increase the cardiac output and systolic blood pressure. By increasing the arterioconstriction, we reduce the movement of blood from arterial side to the venous side, and blood which is trapped here, even during diastole, it maintains the pressure up. Is it right? The story is not yet over. Meanwhile, angiotensin II will also go to cells here, and these cells in the outer, what is this? Zona glomerulosa. These are the cells in outer adrenal cortex. These cells are called zona glomerulosa. And what are the receptors here? These cells also have receptors, which are receptors for angiotensin II. When angiotensin II work here, what happens? When angiotensin II work over here, these cells start releasing a substance called aldosterone. Angiotensin II will act on zona glomerulosa and lead to the release of aldosterone. What this aldosterone will do? This aldosterone, now let's see how aldosterone work. Okay, I will draw just one cell here. This is one cell I have enlarged, and this cell is called principal cell. principal cells or P cells in last part of nephron. Usually they are in the second half of the distal convoluted tubules and they're present in collecting tubules. What are these cells? Principal cells. Actually, this is, let's suppose, the nucleus of principal cell. It has different genes here. Of course, every nucleus has genes. Now listen. What aldosterone will do? This aldosterone, which is released by, from where? Zona glomerulosa, it will come into circulation. Through the circulation, it will reach to the P cells. And what it will do? This aldosterone will come here. Let's suppose this is the aldosterone. When aldosterone enter into this cell, there it will find the receptors for aldosterone. And let's suppose this is the receptor for aldosterone. So this is a very special type of protein which act like a key. And this key is operated by which substance? Aldosterone. This is aldosterone operated receptors. What they do? As soon as aldosterone bind, this protein rush to the nucleus and open the locks of the genes. What is it is going to do? Open the locks of the genes. When gene number 1 is opened by this aldosterone receptor complex, gene number 1 start making a special type of protein, and that protein is planted into basolateral membrane. What is this? Basal side and lateral side of which cells? Principal cells. So these special proteins are planted into basolateral membrane under the direction of aldosterone. What these proteins are doing? Are they doing anything important or just Paris fashion? Yeah. What these proteins are doing? These are sodium potassium ATPases. They are present in every cell. But in this kidney cell, they are present on basolateral membrane and not present on luminal membrane. But under the direction of aldosterone, the concentration of sodium potassium ATPases on the basolateral membrane has been increased. So what really happens that these cells, these are sodium potassium pump. So they keep on throwing the sodium from the cell to extracellular environment. So cells start throwing the sodium from its cytoplasm to the blood. And at the same time, you must be knowing, they are accumulating in the cell. What is this? Potassium. These are sodium potassium pumps. So it means under the influence of aldosterone, principal cell start throwing the sodium from their cytosol to the interstitium and start accumulating potassium. So these cells become extremely poor in sodium and extremely rich in potassium under the directions of aldosterone mediated enhanced sodium potassium ATPases. Then gene number 2 is also activated by the same. Gene number 2 is also activated by the same receptor system, aldosterone receptor. When second gene is stimulated, this produces a product which will not go to the basolateral membrane, product will come and it will be planted into, what is this? Luminal membrane. The special protein, which is product of the second gene, this protein fits into luminal side. And what is this protein? This is sodium channels. These are not pumps, these are simply channels. They let the sodium pass freely as sodium want to move. Now, whatever little amount of sodium will come here, if the cell is extremely poor in sodium, sodium will rush in. You know, things move from high concentration to low concentration. As soon as sodium come in through the pump, it is thrown to the blood. This is how sodium is reabsorbed under the direction of aldosterone. That aldosterone first enhances the activity of the sodium potassium ATPases, so that cells keep on pushing too much sodium from the cell to the blood. Cells become extremely poor in sodium. Then sodium automatically starts shifting from the, what is this? Nephron lumen to the cell and from the cell to the blood. Is that right? So that sodium which was about to be lost into urine is reabsorbed. And you know who loves to follow sodium? Who loves to follow sodium? I think it's water. right? So naturally, sodium is reabsorbed. Along with that, water is also reabsorbed. And of course, cell was rich in potassium. So third gene is activated, and third gene make potassium channels. And potassium is more inside the cell or in the lumen? Inside the cell. Even he knows, good. So what will happen? Potassium will start leaking out. So under the direction of what? Under the direction of aldosterone, principal cells start reabsorbing sodium and water to the blood and start secreting the extra potassium into urine. Is that right? Now, this salt and water, or you can say simply sodium and water, which is retained in the blood, they will decrease the blood volume or increase the blood volume. So it's very easy. If blood volume is increased, then venous return will, yes, increase. So cardiac ventricular fillings will increase, ventricular contractility will increase, and systolic blood pressure will go up. This is how aldosterone, by retaining salt and water, take the systolic blood pressure up. Another support to that. Angiotensin II has done this work through the aldo. Now angiotensin II will go to the central nervous system. I think it's a long travel. And it will work on receptors present in the hypothalamus. Angiotensin II will go and work with the receptors on hypothalamus and force some neurons in hypothalamus, and they will activate action potential which will reach to the posterior pituitary, and from there what will come out? Don't tell me any funny thing. What will come out from posterior pituitary? ADH. Don't tell me oxytocin. That is not going to help the patient right now. Right? So now angiotensin II has made a long travel going to the hypothalamus, stimulate which nucleus? Angiotensin II. ADH. Supraoptic nuclei. Excellent. Supraoptic nuclei are stimulated, and eventually the supraoptic nucleus have the nerve endings in posterior pituitary still, and from there ADH come into blood. What ADH will do? I will not go into detail. Just trust me, I'm right. What ADH will do, it will make the last part of the nephron more permeable to water. It will, under the direction of ADH, right, the cells of last part of the nephron become more permeable to water. Is that right? And you know that last part of the nephron is going to medulla of the kidney. Is that right? And when this nephron is moving towards the medullary interstitium is hyperosmolar. Do you know that or not? When I will teach you kidneys, you will know that very clearly. That medullary interstitium is hyperosmolar. Osmolality here is very high. When this part of the nephron become water permeable, here fluid is hyposmolar, here fluid is hyperosmolar. Water will move from hyposmolar area, it will be pulled to hyperosmolar area. So water will rush from where? Yes, from the last part of the nephron, from the lumen, water will rush through the cells to the interstitium. So there will be increased water reabsorption so that water should not be lost into urine. Is that right? And this water which is coming back, it's too easy to understand. This water will increase blood volume, increase venous return, of course increase cardiac filling, increase contractility, increase stroke volume, increase cardiac output, increase systolic blood pressure. Again we reach to the blood pressure, it again reaches the blood pressure. Is that right? Am I clear? Any other function of angiotensin II? Extremely important function of angiotensin II yet not mentioned is, it is a super stimulator of sympathetic nervous system. This is a super stimulator of sympathetic nervous system. So angiotensin II receptors are present even lot of component of sympathetic nervous system. So what really happens? Look here. Central sympathetic outflow will increase. Number one. Then these cells in the ganglia, sympathetic ganglia, they are also stimulated. First, central sympathetic outflow is stimulated, then these ganglia are stimulated. Then if this is the postganglionic nerve ending, let's suppose this is the target tissue on which this nerve ending is ending. This target tissue may be venous smooth muscle, this may be arteriolar smooth muscle, or this target tissue may be myocardium. Normally what happens, that postganglionic sympathetic nerve endings release norepinephrine. Norepinephrine work on the receptors. And once norepinephrine, which is released and has done its action on the receptor, 80% of it is taken back by the nerve ending. Is that right? This is normal physiology. Now what angiotensin will do here? Angiotensin II has receptors here also. It will stimulate the nerve ending in such a fashion the release of norepinephrine will be increased and reuptake of the norepinephrine will be reduced. So amount of norepinephrine which is present in this area is reduced or increased. If nerve ending is producing more norepinephrine, if nerve ending under the direction of angiotensin II is releasing more norepinephrine and not recapturing it, then amount of norepinephrine present in the synapse is less or more? It is more. If you are releasing something more and not taking it back, so that thing will be there less or more. You know it. So in this way, norepinephrine will be more in this area, and even angiotensin II has receptors which increase the adrenergic receptor concentration on the target tissue. So it means what angiotensin II is doing? It is increasing the whole parameters of sympathetic nervous system, increasing the central sympathetic outflow, increasing stimulation of sympathetic ganglion, increased stimulation of sympathetic nerve ending, increased responsiveness of target tissue. I will see what will happen with this. Look, if sympathetic nervous system works more on the veins, veins will constrict. When they will constrict further, more increase in venous return. Now you must tell me. More cardiac filling, more contractility, more cardiac output, and more stroke volume. More increase in systolic blood pressure, right? This is venoconstriction. Meanwhile, when sympathetic activity is increased on the arterioles, more arteriolar constriction and increase in diastolic blood pressure. When sympathetic activity increases and releases more norepinephrine here, more release of renin, whole system is amplified. Is that right? And then we should not forget something very important. Angiotensin II has receptors on the central thirst system. So when angiotensin II work on those group of neurons which control the feeling of thirst, patient who is bleeding, he will feel thirsty. Of course, he will ask water, and if you have it, he will take the water and try to increase blood volume. Again, that is helpful. By all these means, what angiotensin II, I must say, by all these means, renin angiotensin aldosterone excess, what it is doing? It is trying to elevate the blood volume and blood pressure. Is that right? Am I clear to everyone? No problem. This is physiological functions of angiotensin II and aldosterone. But one most important pathological function I did not tell you. There are some diseases in which blood flow to kidney is chronically low. For example, if you have congestive cardiac failure, if you have a cardiac failure, heart has a very poor cardiac output. For example, I have very severe heart failure. My systolic function or contractility of the ventricle is very poor, whatever the reason. If my heart is a poor pump, my blood flow to every organ is reduced, including blood flow to kidney is reduced. So all those patients in which heart fail as a pump, cardiac output become less, then blood flow even to the kidney is reduced. And in these patients, there is chronic activation of renin angiotensin aldosterone axis. You understand it? In the same way, who as person has cardiac failure, of course his blood pressure also drops, so sympathetic stimulation is also chronically activated. So patient who have congestive cardiac failure, right, in them there's chronic sympathetic activation and there's chronic renin angiotensin aldosterone activity. When angiotensin II level is chronically increased, then something really very bad happens. what happens? If angiotensin II is chronically increased and aldosterone is chronically increased, this chronically increased angiotensin II, right, and aldosterone will work on the myocardium and change the morphology of the heart. This is something which is recently discovered, but very, very important. The patient with congestive cardiac failure have chronic elevation of angiotensin II and aldosterone, and they chronically work on the myocardial cell and fibroblast there. They stimulate the proto-oncogenes, genes which are concerned with growth. These all myocardial cells start producing growth factors. If myocardial cells start producing growth factor, and these growth factors which are produced by the myocardium work on the myocardial cells, so myocardial cell undergo hypertrophy. But this is not normal hypertrophy, it is pathological hypertrophy. At the same time, myocardial cells and fibroblasts start producing extra amount of connective tissue. So myocardial cells become abnormally enlarged, and in between the myocardial cell, lot of fibrotic tissue and extracellular matrix is deposited. And these things, under chronic influences, lead to alteration in geometry of the heart. Chronically elevated aldosterone levels and chronically activated angiotensin II level in congestive cardiac failure lead to morphological changes in the heart. What are these morphological changes? Myocardial cells undergo pathological hypertrophy, and they undergo pathological production of extracellular matrix and growth factors and many other alterations. Those all alterations in a lump sum, they are called cardiac remodeling. So we can say that in congestive cardiac failure, due to chronic elevation of angiotensin II and aldosterone, myocardium undergo progressive pathological geometrical changes. Or we simply call it, as Dr. Rao said, we simply call it myocardium is undergoing remodeling phenomenon. This chronic remodeling of myocardium makes the myocardium more poor contractile machinery, and patient with congestive cardiac failure under the chronic influences of angiotensin II and aldosterone go under progressive cardiac failure. Is that right? In the same way, chronically elevated angiotensin II and aldosterone also work on the smooth muscles of vessels and bring pathological changes in them. So this is one of the most modern concepts, that if you allow the renin angiotensin aldosterone axis to work pathologically high, that will eventually disturb the whole efficient geometry of the heart, as well as vasculopathies are produced. Is that right? That is why any patient with congestive cardiac failure at any stage that comes to you, either at very early stage or late stage, the most important drug is drug which inhibit the angiotensin converting enzyme, so that angiotensin II should not be produced and aldosterone should not be released. Or alternatively, we use the drugs which block the receptors of angiotensin II, so that angiotensin II receptor blocking drugs are also very effective, and not only they change the preload and afterload and blood volume, but they also reduce the pathological, progressive, geometrical changes in the heart. They prevent the cardiac remodeling. We'll discuss in detail what are these drugs and how they work in the next session.